Great. Okay, so welcome to day 2 of a third week in this program. We're more than excited to have Professor Matthias Friedrich with us. He is the director of the cardiovascular imaging program at the McGill University Healthcare Center. He's the former president of the Society for Cardiac MRI and a huge proponent of using advanced research techniques in clinical practice. A lot of his research is focused on state-of-the-art CMR techniques that involve multi-parametric imaging, deep learning algorithms, as well as looking at relationships between anxiety and cardiovascular disease. We're happy to have you here, Professor Friedrich. You can go right ahead.
Thank you very much. So thank you very much also for the invitation. It's a pleasure and an honor for me to present to you. The topic that I was asked to talk about is myocardial stress with CMR. So I will cover what is currently being done in clinical research, in clinical applications, but also what is coming up next. So first, I want to disclose that I'm also involved in software development and I'm an advisor to companies. Okay, so, but none of that should be a significant conflict of interest for what I'm talking about. So let me first open the background a little bit of why we're talking about cardiac MR in the first place. So in cardiovascular medicine, we have to make sure that we do not just pay for what we can do, but pay for what makes sense. And this is also known as value-based care. So we pay for things that eventually improve outcomes and not just procedures that can be done. So that's number one. Number two, health management has to become more personalized. So guidelines are nice, but for the individual, they may not be that relevant. So we have to find out who specifically benefits from which diagnostic and therapeutic approach. And then last not least, that we are also better so that it doesn't happen that there's a question from some clinician and the radiologist has to give the answer, and then there is a treatment somewhere. There has to be, and good radiologists, they will always ask for additional clinical information, but this process has to be formalized, standardized, and also optimized. So we have to integrate other parameters. And we are involved in a lot of research at McGill, where we use actually massive data around lifestyle, blood tests, microbiome, etc., in a large program, the cardiovascular signature program, to identify which of these parameters are important and then to generate what we call a signature or fingerprint of health. And this is what has to be automated. And those who are getting now into cardiac imaging will have to prepare in the future. We have to not just use the images, but automatically integrate the heart rate during the scan, the breathing, the respiratory rate, blood pressure, oxygen saturation, age, sex, and medical history, basically to automatically integrate that. Eventually, it is about the information per dollar spent, and this is why MR is so important, because MR provides per minute more information than any other imaging modality, and that's mainly due to its versatility. So with cardiac MR, you can do pretty much everything all the other imaging modalities in cardiac imaging can do, but typically at least as good as that, maybe better in several areas like morphology and function and flow. And recently has been shown that perfusion imaging, and we'll talk about that today a lot, outperforms nuclear imaging for myocardial ischemia. And maybe the most important unique added value comes with tissue characterization, because this is what no other imaging modality can do. And this includes edema, fibrosis, etc. So it's the most versatile technology. It provides the most quantitative data, even from a single scan. So it also lends itself to the future, which will be a lot about artificial automatically extract information. So the strategies to involve these techniques and to increase the value are reduce the effort by shorter protocols, ideally no needles, no contrast agents, no stress, and increase the output, which is maximize scan efficiency and image quality. At do it all. And I know that Katarina, who spends currently time in Lagos and in collaboration with Lausanne, is involved in setting up a collaboration that would allow Lagos and others to use such sequences. Then ultra-efficient analysis tools that automatic information from the images and integration of other data that I already mentioned. So in the microvascular dysfunction can be endothelium independent or endothelium dependent. Most of what we see clinically will depend on a dysfunction of the endothelium itself. And the endothelium itself can only be assessed when using a stressor or something that directly affects the endothelium. So which is, for example, not adenosine, which bypasses the endothelium actually. Then metabolic problem that at the end of my talk. And then, of course, downstream effects of coronary dysfunction, which is then looking at things like contraction, relaxation, and secondary effects like LV hypertrophy and left atrial size. And for each of these, we have certain methods, but you can see that CMR is basically in all of them. So you have one tool that allows you to do most of what we're talking about, whereas other methods typically have just one or two focus areas. So currently, CMR of coronary vascular function is mostly done using first pass perfusion. First pass perfusion means, and maybe I go briefly to the next slide, you'd inject a contrast agent in the gadolinium, and the gadolinium, you inject that intravenously, and the gadolinium will reach the heart and will then go through the right ventricle, left ventricle, and then to the myocardium, and you see a delayed wash in areas that are exposed to coronary artery stenosis. So this is using gadolinium and the first pass. So the protocol for that, and this is the recommendation that has been published with the endorsement of the Society for Cardiovascular Magnetic Resonance, is a relatively short one. So after the localizer, you perform stress perfusion with, for example, adenosine, and then you look at function, and then you perform the imaging for fibrosis or scarring, so the late gadolinium enhancement imaging, and then you're done. You could add a rest perfusion in between. You could add flow measurements. You could add even coronary arteries. But this is the bare bone first pass perfusion protocol. So a localizer, and then using typically a saturation recovery gradient echo sequence with injection of gadolinium, and then you bridge the time to the late enhancement of function. Now, this is what you get here. We have an example of right coronary artery stenosis, and you see, if you look carefully, that there's a subendocardial deficit in the basal and the mid slice. These are short axis views of the heart. And this approach has been shown to be very efficient. This is from a paper that will appear in the next weeks in JACC. It's an analysis of the GATAGAT2 trial with 588 people, and compared to SPECT, really not even comes close to being similar to MR. And if you look at all the various markers, so the area under the curve, accuracy, specificity, positive predictive values, negative predictive value, every time CMR is better. The only time where CMR statistically is not better, but is not statistically significantly better, but still better to some extent, is sensitivity, where also CMR outperforms. SPECT is just statistically not significant. So this is just one of several trials that have shown that the diagnostic accuracy of CMR is better than that of SPECT. But the more important question is not necessarily accuracy, but what is the impact of outcome on outcome when you use this technique, because eventually that's what it's about. The best images don't help if they don't help the patient live longer or better. So in order to do that, there was this brilliant study published a few years ago in the New England Journal showing against the current gold standard, which is the fractional flow reserve, how well CMR can guide management. So in this study, in 915 people were randomized to either go invasive, get a fractional flow reserve, and make a decision based on that, or get a non-invasive cardiac MR scan with a first pass perfusion, and then have a decision based on that. And the result was that there was no difference between the two groups. So it didn't matter whether patients had a therapeutic decision based on FFR or on CMR. Now, given that FFR is currently considered the gold standard, that shows that CMR is just as good as the current gold standard. But on top of that, and this is in the paper, just we have to read carefully, but the important point on top of that was that this outcome was achieved with less invasive procedures in the MR-informed group. So there were less revascularizations, less bypass grafts, and less stents implanted. So basically, the information was actually better. The guidance was better and cheaper when it was done with MR instead of an FFR. So this is an important study. Of course, the prognosis is also important, and there are also, in the meanwhile, about 30,000 people have been published on that, but this is just one of the more recent and biggest ones, 3,600 people, where CMR was clearly very predictive of outcomes. So a normal versus an abnormal first pass perfusion test, it has important prognostic information, even when compared with CT. So the prognostic value of stress MR in symptomatic patients with coronary artery stenosis on a CT was excellent. It is clearly a very important prognostic marker as well. So based on all that, the summary of the CMR recommendations in a multi-societal guideline is as follows. In patients with acute chest pain, no known coronary artery disease, CMR is comparable to other tests, and it is also the same in known coronary artery disease, including former bypass. In myocardial pericarditis, it's specifically a class 1 indication for CMR. The role of other techniques is much less important. And in stable chest pain, it's also that for all of these, CMR has been deemed comparable to other techniques. No known coronary artery disease, intermediate to high risk, more in other guidelines, it's more the low to intermediate risk. Then coronary CT plays a significant role, but CMR can also be performed in those. So this is for coronary artery disease. The bottom line here is first pass perfusion is feasible, is clinically safe. There are almost no serious side effects. It is accurate, it guides management, it has a very good prognostic value, and there is a societal agreement that CMR can be used just as any other imaging modality. And in certain cases, when there's suspected myocardial or myopericarditis, then it is actually recommended instead of others. So that's in coronary artery disease. But we also know, especially from disease like INOCA or conditions like INOCA, so in ischemia with no obstructive coronary artery disease, that the microvascular function actually plays a significant role. And this was highlighted in a recent very nice review by Harmony Reynolds published last year. So the microvascular function, even in the absence of coronary artery stenosis, may play a big role. And this is where other techniques come in. Now, macrovascular function so far has been not well assessed in clinical settings. It was more rule out diagnosis, and which was not necessarily that well understood. And you can look at endothelial function by some diagnostic procedures, but they are either complicated or expensive or both. So you can perform a coronary angiogram, inject acetylcholine, and then watch what happens with the blood vessels. And in a normal subject with healthy coronary arteries, and acetylcholine will lead to vasodilation and an improved blood flow, etc. Whereas in a diseased person, very likely you have a vasoconstriction or no vasodilation. So this is an invasive test. Another test that has been promoted was based on PET, so positron emission tomography, where you quantify blood flow injecting a radioactive tracer, and then you do this also with endothelial stressors. However, the validation of this technique so far, the data are very scarce. So about 20 years ago, it was, let's say, there was a move introducing oxygenation-sensitive MR to cardiac imaging. And this is a technique that is relatively new, but it is very interesting because it does not require a contrast agent, and therefore can be repeated, can be applied repeatedly in the same setting, but also very safely, and is also much more cost efficient because contrast agents in most countries actually are a significant cost factor. Now, oxygenation sensitive MR actually started earlier, more than 30 years ago, by this seminal paper where for the first time it could be shown that the bold effect can be used to assess changes of oxygenation. Now, the bold effect is simply based on the observation that when you deoxygenate hemoglobin, the signal intensity drops in sequence that are sensitive to this effect, because deoxygenated hemoglobin has different magnetic properties than oxygenated hemoglobin. So in other words, deoxygenated hemoglobin, if it increases, it acts like a contrast agent, reducing the signal intensity in these images. So we started actually our first experiments where we just inflated a blood pressure cuff in the upper thighs and then watched what happens in the calf. And when we inflated the cuff above the arterial blood pressure, we could actually watch the signal go down as you have a deoxygenation of the tissue. So this has been used in the brain for functional MR since the early 1990s. It took a few years until we had the first clinical studies. So this is one where we could show that this effect can also be observed in the heart in patients with severe coronary artery stenosis when you give adenosine, because adenosine leads to vasodilation. But if you cannot vasodilate, then it does not happen. And in critically stenosed vessels, that means that with adenosine, with a mild increase of the cardiac output, you even have a deoxygenation. So we observed that, but the early techniques that we used here was an echo gradient, a gradient echo sequence with an EPI readout. Also had a lot of scatter, so it was clinically not that useful. But fast forward, the techniques have improved, and now most centers use a cine sequence that is based on an SSFP, so a standard state-of-the-art cine sequence. And what was shown here by work in Calgary from Judy Liu is that compared to patients with a normal FFR of a coronary artery, patients with a reduced fractional flow reserve have a much stronger decrease of the signal intensity or a lack of increase of the signal intensity, and which perfectly separated one from the other. So you could use adenosine and vasodilation to induce a difference between normal and stenotic areas and detect by that significantly stenotic coronary arteries. But then we added something else, and it was actually based on an observation that was as follows. I had this kind of stupid, naive idea, thinking that if the patients hold their breath for a really long time, as long as they can, there should be a slight decrease of the oxygenation that's maybe pronounced in patients with coronary artery disease. So we kind of expected that at the end of the breath hold, we would have a lower signal intensity in these regions. But then what we actually observed was a bit different. In healthy people, in patients, there was no change. So before and after was pretty much the same thing at the beginning and the end of the breath hold. And then even more surprisingly, in healthy people, we saw an increase. So that was initially totally counterintuitive. Why should oxygenation increase when you hold your breath? But then the explanation, as often, was already around in old physiology books. And this is the most complicated slide I want to show you here. So this is actually from a German paper from 1966. And this study could show that if you change carbon dioxide, and if you hold your breath, you change that significantly. And if you hyperventilate, you also change it. So if you hyperventilate for a minute, your coronary blood flow actually drops by almost 25% because of the ability of carbon dioxide to act as a vasodilator. So the carbon dioxide is a vasodilator. If you breathe it off by hyperventilation, then you reduce your coronary blood flow. And then the opposite happens when you hold your breath. If you hold your breath, the CO2 is not exhaled, is produced still in the body. So you have an increase of the vasodilative CO2, which leads to vasodilation. And by this maneuver, first hyperventilation and then breath hold, you can actually increase your coronary blood flow by 100%. So this has been shown before. Now, this is basically the background why we use the following protocol. We ask people to breathe normally, assuming that this is reflecting their normal vascular tone. Then we ask them to hyperventilate for 60 seconds, which leads to vasoconstriction because the blood CO2 drops. With that, the myocardial blood flow and volume drops, the myocardial oxygenation drops. And with that, because of the bold effect, the oxygenation sensitive images show a lower signal intensity. So this is in healthy people, a vasoconstriction. And then the opposite happens, it reverses the vasoconstriction if they hold their breath, and there is even an overshoot. So from the beginning of the breath hold to about 30 seconds, you see that you see the entire vascular capacity coming from vasoconstriction to vasodilation. So we have used this in athletes, and you could see that even a breath hold of 2 minutes even still comes with a net increase of oxygenation. And by the way, the same happens in the brain, because CO2 is a vasodilator in the heart and the brain. And if you ever try that breathing maneuver yourself, and it's, by the way, also what some recommend as a therapeutic agent or a therapeutic exercise, and some even swear that it cleans up their mind just as meditation does. So there's no harm with doing that. So if you can increase then the cerebral blood flow and the myocardial blood flow. So then by the breath hold, and then when people hyperventilate, the opposite happens. That's why hyperventilation comes with reduced cognitive function and comes with a reduction of blood flow in the prefrontal cortex. And that's why panic may lead to more panic, because panic comes with hyperventilation. Hyperventilation comes with a reduced blood flow in the prefrontal cortex. Reduced blood flow in the prefrontal cortex causes a loss of control or a sense of loss of control. This causes anxiety, and you start the vicious cycle again. So after this, we have, this was work by Katie Fisher in healthy people, comparing it to adenosine. So she could show two important findings when compared to the cavity blood, where there is no real change whatsoever of the oxygen level, because oxygen doesn't change that quickly. It takes time, and everybody who works on the intensive care unit knows that. Where, however, in the myocardium, on average, in healthy people, after 25, 30 seconds, you reach a peak, but after the signal intensity reflecting the oxygenation increases. Now, this effect, when you compare it with adenosine, is pretty strong. It's actually stronger than adenosine in both directions. So hyperventilation causes a more significant change of signal intensity than adenosine, a net change, and the same for 15 and 30 seconds of the breath out, and at the max even a little bit more. So this was comparison with adenosine. And then we went ahead and did some animal studies where we induced coronary artery stenosis and performed the breathing maneuver in anesthetized pigs, and could show that the breathing maneuver can actually elicit a difference that, again, when compared to adenosine, was at least as strong, if not stronger, and allows to identify the area that is subtended by the coronary artery stenosis, and that correlated with the FFR and was a clean experimental proof. Now, Katie Fisher went to Bern, where she still leads a research group, and there she performed a clinical trial in patients with suspected coronary artery disease, and she could show the same thing, that when compared to remote territory that behaved like normal myocardium, the stenotic territory did not have a signal intensity increase, but stayed basically the same. And the global microvascular dysfunction even performed worse. So these are patients with severe diabetes or severe hypercholesterolemia, where the capillary system is not working properly. The application of this technique is not only confined to coronary artery disease, but also is useful in heart failure. So in this study, myocardial oxygenation problems were almost as frequent as changes of the circumferential strain, and was among the top abnormalities in heart failure with preserved ejection fraction. So if you think about it, you can, in the same scan, you can perform a study of the anatomy and function. In the same images, you can actually qualitatively and quantitatively assess strain, and you can add tissue characterization. So it's a comprehensive scan that doesn't require any contrast agents. Now, some of these results have been reproduced by other groups. One of them here from the Harvard Medical School in Boston, in patients with arterial hypertension. And here's a study from China. They even had already a significant difference where the 10-second breath out could identify infarcted tissue and differentiate it from salvage tissue and normal tissue. Now, the breathing maneuver can also be applied without oxygenation sensitive imaging, but just looking at strain. And this is what we did at the University of Heidelberg, where instead of adenosine, we used this breathing maneuver and could show that the strain was significantly abnormal during these breathing maneuvers when in patients with coronary artery disease in these regions when compared to normals. And this was also a test that just took about a minute. And it also could be applied in patients with acute coronary syndrome and with an extremely high diagnostic accuracy of more than 95%. The breathing maneuvers together with strain imaging could identify those with acute coronary syndrome. In a very recent study, and it's actually in press, the paper now should come out in a few weeks, we applied this, what we call breathing-induced myocardial oxygenation reserve, or BMOR, in heart failure, where we added also an assessment of the brain, where we applied the same breathing protocol. and then compared it with the cognitive function in patients. So in long story short, in patients with heart failure, related to the cardiac output, cognitive function was related to the microvascular function in the brain, but also to the myocardial oxygenation reserve in the heart. And the two, brain and heart, so B more and B core for breathing-induced cerebrovascular oxygenation reserve, correlated. So this explains why patients with heart failure have a reduced cognitive function. The lower cardiac output is associated with a microvascular dysfunction in both the heart and the brain. And the brain microvascular dysfunction is associated and likely causative for the cognitive dysfunction. Of course, you can combine then the B more with strain, and this is what was done and published last year in Bern again, where when you combine the two, you can further increase the diagnostic accuracy, in this case, to an area under the curve of 91%, to identify patients with coronary artery disease. So this is a test that is useful in microvascular dysfunction. In macrovascular dysfunction can be combined with strain in same images, by the way. So a very efficient 3-minute test, which also is preferred by doctors and patients, as we could show in this study published last year, where both referring physicians and patients had a preference for this test. Because of the convenience and also safety issues and cost issues. So it was the preferred test above any pharmacological stress, like stress echo or stress perfusion CMR, but above CT coronary angio, mainly because of the radiation associated with CT and exercise echo and PET. So it's also referring physicians and patients prefer that test. And the combination of the three, so this paper is currently in revision. If you combine the three, heart rate, response, strain, and oxygenation, so all three of them, heart rate response, I didn't comment on that a lot. It's also when you have performed this breathing maneuver, there is also a predictable increase of the heart rate during hyperventilation and a recovery during the breath hold. But this is also dependent on the neurohumeral axis, whether it responds normally or not. So if you add this as a third component, you can also then come to a diagnostic accuracy of way more than 90%. So, and this is how it may look like in the future. So these are images from a company, and I'm involved in that. So just as a disclosure, this is how we will probably see it. So these are maps, dynamic maps of oxygenation, normalized to the oxygenation of the blood, where you can see, in this case, it's an LED occlusion, we can see the lower oxygen levels basically during the cine. So here you can see it's mostly occurs during systole and early diastole. Here's an example of a stenotic right coronary artery, and here's an example of stenosis of two coronary arteries, LAD and circumflex. And here you may notice that right in between, there seems to be an area that is normal. So there was apparently no deoxygenation. And one could say, okay, maybe this is a false negative scan. And then if you look at that, so this is the region, and you compare it with the perfusion, you see actually, wow, the perfusion deficit is mostly in that region. So this really seems to be false negative. But then comes the solution to this. This is a small infarct, and this is the late enhancement imaging with a bright signal of the infarcted tissue. So in fact, it was not false negative, but the perfusion was false positive, because in the infarct, you do not use oxygen. So there is no deoxygenation in that infarcted tissue. It's simply because it's not viable. So this just highlights the potential of this technique. And again, there's no contrast agent, no stress agent, no needles, and it's just a 3-minute data acquisition protocol. Now, you can use these data and then analyze that. You can produce these maps, but we think we can even go further and use machine learning for a fully automated analysis. And this is what we have done, and we presented earlier this year at the Society for Cardiovascular Magnetic Resonance. So we could very accurately identify areas exposed to to significant stenosis. And then we are also putting this to its test in an international multi-center trial. And so these are intermediate analysis of, and we had 6 countries that were involved in that. And here are some examples. But what we observed is that overall, there's still a learning curve in performing the breathing maneuvers. But once this was done, actually only a few patients had to be rejected because of image quality issues. And what was found that there was, when normalized to left ventricular and right ventricular oxygenation, there was a difference between healthy people and patients. And then when we looked at just the bare analysis of the signal intensity, then we had sensitivity of 85% and specificity of 79%. But then when we added artificial intelligence and did a fully automated analysis and looking at automated features, so not just the values and eyeballing, there was actually an area under the curve of 90%, so an accuracy of 90% to identify, and here you see the sensitivity and specificity. 81% is not as good as the sensitivity, but a very high sensitivity to identify segments exposed to coronary artery stenosis. So in summary, let me say that CMR is the most versatile cardiovascular diagnostic tool that we have. First pass perfusion CMR is highly accurate and efficient to assess for coronary artery stenosis. But in the near future, we likely will have access to a needle-free protocol, including LV morphology, function, and coronary vascular function that can be consistently performed within 15 minutes, of which only 3 minutes are the rest would be for localizers and other maybe functional studies or flow studies or mapping or whatever. Further validation, of course, in clinical utilities testing and studies on impact on outcome are required, but we have now a consortium, an international consortium of 23 centers worldwide that is working on that. And we have also a special interest group at the Society for Cardiovascular Magnetic Resonance that will allow us to communicate and to accelerate the development, so that I believe that oxygenation sensitive MR together with breathing maneuvers will be a widely useful diagnostic tool for high throughput, very cost efficient imaging of a coronary vascular function. And with that, I want to thank you for your attention.
This is super, super fantastic. I'm so looking forward to start doing some of these scans with you, Matthias, especially trying to do it in the brain. So it's really good to see, to actually get to learn more about this. I see lots of applause in the audience. So there's already a question in the chat, and I know you have to leave in 20 minutes, so we'll make it brief. Do you think Be More will replace the use of gadolinium? Definitely will actually replace it, or will GAD still be used?
That's a very good question, because gadolinium is not only used for a first pass perfusion MR, which of course is very important clinically, but it's also used for tissue characterization, late gadolinium enhancement being probably the most in the foreground, but also for post-contrast T1 mapping that gives you the extracellular volume. So this is used in various cardiomyopathies and also used in myocarditis or inflammatory disease. So there is still a wide field of applications for gadolinium. Having said that, as we speak, so this morning I had a discussion with one of the students, and her project about using the oxygenation sensitive images only and train a machine learning algorithm to identify features that are associated with scar or with edema or with diffuse fibrosis. So we have some very preliminary early results, and other groups have already looked at the value of cine imaging to detect infarcts. But I can imagine that in the future, not maybe this or next year, but not shortly thereafter, not long thereafter, that we will have opportunities to get rid of contrast agents altogether, even for tissue characterization. So machine learning, while I think there's certainly a hype currently, and we should not think that machine learning can do everything, but machine learning is also very powerful. I have been surprised more often on the positive side than on the negative side about what machine learning can do. And if you train algorithms with good data, there's a lot of information that we visually cannot appreciate, but an algorithm can do that. So if your image quality is good, and if you train an algorithm, then cine images probably, because SFP images have a T2 over T1 weighting. So there's technically both information pieces are a part of the information. So machine learning is able to sort that out and then give us the information. So we're currently working on that. We hope to present something, some preliminary results at the next SCMR in London in February. But over the next year, there will be more in-depth studies on that. So I'm confident that in the future, we can replace gadolinium, not in the near future, but in the mid to long-term future, definitely.
Fantastic. And I see Harrison and Francis have a question, so I'll start with Harrison. Go ahead, Harrison. You have to mute yourself.
Okay. Yeah, so thank you so much for the presentation, Prof. I'd like to crave your indulgence if you could help me explain this more. I know you talked about during the breath hold sequence, there's increased myocardial blood flow and oxygenation. Why is that so? And also, does this apply to healthy patients? And does it also apply to patients that have some 1 or 2 background lesions before now? And then the second question is the BMOR analysis to I see to me it presents like it's the radiologists that will have the upper hand in getting to use this tool. What are the plans on ground to get techs to get to use this tool, especially in low and middle income countries, whereby a lot of data, because with this BMOR to a lot of data, so with science will get to have anti-data, especially from low and middle income countries. So those 2 questions I just wanted to help me to highlight on it. Thank you, sir.
So, so I know that this was is a fairly complex, but once you have gone through the physiology, it's actually pretty clear. So what happens is, as we breathe in and out, we have slightly fluctuating, but overall relatively stable levels of carbon dioxide. Carbon dioxide is a constant vasodilator. So if you increase carbon dioxide, and it's not the absolute value, it's not because if people live at an altitude of, let's say, 2,000–3,000 meters, you have to breathe more to get the oxygen, so your carbon dioxide would be lower. But then again, you have an equilibrium roughly, so that you have your normal altitude-specific level of carbon dioxide, which has a vasodilatory effect. Once you hold your breath, your carbon dioxide will still be produced, but you do not exhale it. And exhalation is very, very efficient in getting rid of carbon dioxide. Once you hold your breath, your carbon dioxide will increase. And with that, the vasodilation induced in the brain and the heart. So the blood flow will increase in both regions. Now, because the oxygen demand does not significantly change in the heart during that time. You have a net increase of oxygenated, a net inflow, more inflow of oxygenated blood than you need. So you have a net increase of available oxygen. So that means you have a decrease of deoxygenated hemoglobin. And deoxygenated hemoglobin, which is typically always present because the myocardium has a significant extraction of oxygen. So you always have a signal that is relatively low of the bold sensitive or oxygenation sensitive imaging. But if you decrease the amount of deoxygenated hemoglobin by offering more oxygenated blood, then this effect is less, so we have a signal intensity increase. And the opposite happens when you hyperventilate. So you exhale a lot of carbon dioxide, so the vasodilatory impact is reduced. So you have less blood flow, and in patients with panic attacks, we all know that in emergency rooms, they often have chest pain, and the chest pain is actually caused by a low, if they are in a severe panic attack, is actually really caused by a low coronary blood flow. So in healthy people, you have an increase of oxygen and signal intensity when you hold your breath, and you have a decrease if you hyperventilate. And you have an increase of heart rate, and you have a change of the strain. But in patients, it's different. So patients, if they already are having a problem with coronary perfusion because they have a coronary artery stenosis, the periphery will already be vasodilated because the system tries to increase the blood flow as much as possible. So there's already an increase of vasodilation happening. So if you on top now perform a breath hold, there is not much capacity to further dilate. So it is, in fact, zero if it's more severe. And then there is something that we know from adenosine, so-called coronary steal effect. So if you have a stenotic coronary artery, it's very stenotic, the distal bed is already vasodilated, then you give a vasodilatory stimulus like adenosine or holding your breath, then all the other distal vessels will dilate and actually steal blood from the poor territory that tries to keep up by peripheral vasodilation. Because of the stenosis, it can't. So then you have a net decrease of the flow into that territory, and then you have a net decrease of the oxygenation. And this is what we observe in severe stenosis. In the brain, it's similar. And but in the brain, we still are learning. We know the effect of hyperventilation and breath holds. This has been known for years, even before we started doing that in the heart. But we have still yet to understand when exactly during, is there variation during the cardiac cycle. We have some preliminary data, actually, that even during the cardiac cycle, there's a fluctuation in the brain as well. So this will be very interesting to analyze that. And also the change across the cardiac cycle in the heart, which we call the oxygenation cardiogram, like the ECG, but just an OCG, the pattern of that, the systolic, so it's also two peaks that we observe. The pattern will probably be just as useful as an ECG to analyze. So regarding the second question of how this could be clinically applied, and about the analysis. So typically, people do not have the time or the fun sitting half an hour or longer to analyze data, drawing contours, etc. So this will not work. We have seen that very early. So that's why I have, together with the fantastic team, that's why we have put together a company that just does this, produce a fully automated software for doing that. So you can do it by hand, by drawing all the contours in all the images and then take measurements. But it took our students, even when they were trained, at least 2-3 hours per patient. So nobody can or wants to do that. So that's why we have said, okay, we have to automate this, and we have to add machine learning to extract certain patterns that are even visually not apparent. Now, what we want to do now is offer that software for free for early adopters, and teach them to become teachers so that they can teach others how to use that. And our company is not. We do not have venture capitalists that force us to make a ton of money, or so we can really do this to support the research and to get these centers going. So this is our attempt to make it possible. Of course, it has to go through FDA and CE certification. So there's still some ways to go, but we hope that by providing the prototype now to key centers, that we allow them to get started and to use it in their patients. So I hope that answers your questions, Harry.
Perfect.
No.
Thank you very much, sir.
That's a very good question. And I guess, Matthias, will probably talk about this later, but there are quite a few centers that are participating in this training that may be willing to implement the Be More. And also, we probably can have conversations about which centers we can target in Asia and Latin America for this software access as well. Yeah. I was very mindful of your time. I know you have to leave in 7 minutes. We're going to take one last question. I think, Francis, you had your hand up, but before that, is there anybody else that has a quick question for Professor Friedrich before he... It's a very busy man, so... Francis, do you still want to go ahead and ask your question? You have to mute yourself. I don't know if we've lost Francis.
While he's still unmuting, I wanted to mention one more thing about the first pass perfusion. So there are now ways to facilitate that, and I just want to make sure that I have also talked about that. So there is a newer approach to what we called AQUA. AQUA is automated quantitative perfusion. So this would allow, and there are several software vendors around there that will provide that tool, but that allows an automated analysis of the first pass perfusion. So you give the gadolinium, you take the images, and then the software will analyze. I'm not actively involved in any of these companies, so it's not. That's not. I'm not talking about what we do there. So I cannot vouch for any of the companies, but there is software out there that allows to quantify and automatically the blood flow based on the first pass perfusion imaging. So that's certainly currently a very interesting alternative for those who want to and can use gadolinium. So they could analyze the images visually, but also have them analyzed by this technique. So I want to make sure that this is also mentioned.
No, this is fantastic. Francis, do you still have a question, or because we have to be very mindful of Professor Friedrich's time?
Yeah, so he's still muted.
He's still muted, yeah. Any other questions? We could...
Udona, I'm happy to take any question.
Hello?
Yes, Francis.
Okay, here you go.
Yeah, can you hear me now?
Yes.
Yeah, we can hear you.
Yeah. Thank you, Prof, for the presentation. I just wondering on just the figures that we are normally using for the T1 and the T2 mapping. Since most of these research, you use volunteers from the Western parts of the world, I'm just wondering, is it accurate or is it reliable for us to also rely on these figures for the parts of the world that hasn't, established any normal range for these figures? And we still use it, and how accurate would that be? Thank you.
So I'm because I could not hear very well. Are you talking about T1 mapping in general or T1 mapping for perfusion scanning?
Yeah, just T1 mapping in general. I mean, the normal range.
Yeah. Okay. So that's
valid.
yeah. So T1 mapping, and I have been, in fact, we published the first clinical paper on T1 mapping in 2003, which is already 20 years ago. I have to say, I have worked on with all vendors and different field strengths, and we tried very hard, but my take on T1 mapping is that we are not at a level that we can really reliably apply it in patients and expect it to be informative in all the cases. So in our center and at McGill, we use two different scanners, two different vendors, two different field strengths. I would say the real value of T1 mapping is very high in when you have to rule out Fabry's disease. It helps with myocarditis. It helps a lot with amyloidosis. But in many cases, we are a little bit disappointed with the quality, the consistency, and the reproducibility. So I would not necessarily base my complete, let's say, a decision on the diagnosis on T1 only. Now, having said that, we have young patients who come for myocarditis, for example, and it's for ruling out myocarditis. And if these patients have a very strong clinical suspicion, we often decide to not give contrast agents and just do a CINI, a T1 map, and a T2 map. So hoping that both the T1 and T2 have the same appearance, either really positive or really negative. Now we come into a problem when one is positive, one is negative. Then we have to ask the patient come back again to then give contrast. So this happens, I would say, in about 10, maybe 20% of the cases. So the short answer would be T1 mapping is difficult. It is helpful, but it is not robust enough to say, okay, if we have T1 mapping, we can answer all these questions.
Yeah, it's very, yeah, go ahead, Francis.
Yeah, thank you for the answer. But my question was mostly based on the population group that you use in those research. I understand that most of these were like the Western healthy volunteers that you used to establish those normal values. In any case, if those values are even accurate, is it reliable for us to apply it in the other part of the world that hasn't done any research concerning those values?
Yeah, so when you talk about normal values, what I am, to be very honest or very transparent, I am a proponent of using Z-scores. And Z-scores means you establish for your system that you have your normal values, and then report the deviation of your normal values from your normal values. Because you cannot, unfortunately, you cannot just take, we have a 1.5 Tesla Siemens machine, and we take these normal values published for the other 1.5 Tesla Siemens machine. This works, but doesn't work very well. So you would have to, and one way to do that, the clean way, is to invite healthy people who are absolutely healthy with respect to everything you can do, and take several age groups and have at least 5 or 10 people per age group, and then have your normal values. The other way that also works sort of is if you have patients that way you're asked to rule out disease, but they, clinically they are totally normal and they just had an episode of atypical, whatever, chest discomfort or palpitations, and everything is normal that you see in the MR. There's nothing abnormal that you kind of save them as normals. So this is the other way, but I would strongly suggest that you perform your own normal values then for each system. So we have done that at our institution, and we even had to had to study another group after the software was updated. So even a software update may change your normal values. So this is one of the disadvantages of mapping.
Mm-hmm. Yeah, that's a big one. We see this a lot in brain imaging. And I was going to say the same thing, and I'm glad Francis asked that question again, because normative data is always a huge problem, especially when you have scanners and sequences that tend to change with software updates. So that's really good to have a center-specific normative data. The question is, how do you generate those normative data, and who's going to pay for that? But that's a different question. Okay, Matthias, we don't want to take a lot of your time. We thank you so much. We know we'll be seeing you again on October 2nd when we do the webinar with the cardiologists invited. This will be a bit more for the cardiologists, but we are very happy to have you back again. If anybody else have a question, you know what the drill is, send us an email. We'll compile the questions and then send it to Matthias and get your questions answered. Matthias, thank you so much. I'm sure we'll be seeing you very soon.
And I wish everybody who's getting started all the best, and also for all your people. And if I can help, I'd be really pleased and happy to do so. All the best and take care.
Thank you so much.
Thank you.
All right. Bye.